So then to segue over to a different subject, like I said, Matt talked about the treatments for diabetes, both from a medication standpoint, pill-wise, and then an injectable standpoint. Now I'm going to kind of cover some of the other treatment protocols, again going back to the concept that diabetes is a cardiovascular disease process. So we have to discuss that. So key questions, why do we pay so much attention to this part, which we've hopefully hammered home by now? What parameters are we using? These become a little bit murky, but especially because of the ACCORD trial results that have come out as recent as March. There's non-drug recommendations that are included with that as far as your exercise, salt intake, so on. Which drugs, how many, because patients inevitably start complaining about the number of medications they're on at this point. If you have a 50-year-old who's diabetic and has high blood pressure, now you're throwing in medicines for cholesterol and aspirin and all this other stuff along with it, they start getting pretty grouchy at this point. And then should recent studies change our goals? Well, we'll kind of leave that a little bit open-ended, but we'll discuss it as they come up. And what do we do about the resistant cases that we start seeing where there are medical issues, kidney function, and so on, preclude certain medication treatments? First of all, volume expansion, dealing with diabetes and hypertension. You might recall back from my earlier lecture, I talked about the pro-inflammatory, pro-thrombotic components of things and the nature of volume expansion. First of all, higher insulin levels, not sugar levels, but the insulin levels, trigger higher sympathetic activities, okay? Your noradrenergic issues tend to kick in. Your higher sugar levels also lead to higher sodium resorption. So logically, water follows salt, and you get more intravascular volume issues as well. Keep in mind, when you talk about serum osmolality, that with your equation, what are the three things that factor in when you're calculating osmolality? Well, board question. Your sodium, glucose, and your BUN, your kidney function, okay? So 2 times your sodium plus your glucose over 18 plus BUN divided by 2.7. So that's your serum osmolality. So that does play a role, albeit much smaller than your sodium, it still plays a role in your serum osmolarity. Yeah, then you have the decreased arterial compliance, that we kind of talked about that a little bit earlier too, and the obesity. More of a, almost like a barometer in some ways, that the more obesity you have, the more pressure you have and hydrostatic forces in your lower extremities. So UKPDS, blood pressure study, tight versus less tight control. You look at your risk reductions down all these series of issues, any diabetic endpoint, diabetes-related death, heart failure, stroke, MIs, microvascular disease. Of those, the heart attacks was the only ones that were not statistically significant, but all the rest of them really did show a genuine improvement in outcomes by having more tightly regulated blood pressure. Kaplan-Meier plot. In case you're curious, Kaplan-Meier just means you have a series of step-ups. It's not a smooth line. So as an event occurs, it bumps the level up and it just keeps slowly stepping its way up. So there's nothing special about it. You're looking at the 2 different medication treatments. Again, less tight control leads to higher percentage patients of events down that left side. So your top line in particular is indicating that, again, less tight control leads to more problems versus either an ACE inhibitor or a beta blocker for control. So then your HOT trial, I think that was hypertension optimization treatment trial. The effect on diastolics was what they were focusing on. The interesting thing is the right side of that graph. On the right side, those are non-diabetic patients. So if you shoot for a diastolic pressure of 90, it didn't have any significant change if you try to be more aggressive and knock it down to 80. So these are all non-diabetic patients. Over on the left, where you have a diabetic patient, there was a tangible benefit. So you're focusing on the blood pressure reduction diastolically specifically, and you get a 48% risk reduction out of that. So again, the conclusion being that diabetics are far more responsive to improvements in blood pressure than non-diabetic patients. Then an article that came out March 14th, talks about one of the latest ACCORD developments. We already talked about in February of 2008, they axed the blood sugar arm of the ACCORD trial. that very clearly by knocking people's sugars too low, below 6 in that area, people were dying at a faster rate, so they chopped it off. Now, the other two arms, which involve cholesterol and blood pressure, actually wrapped up in 2009, but we're just seeing all the data being processed. And they focused on these different blood pressure parameters. The only purpose of this graph is to show where these blood pressures were ultimately following over this 8-year span. Okay, so don't read into it too much. It's just that this is your average difference around 134 versus about, close to 120. Okay, so we go to the next slide, which actually interprets that data. And unfortunately, there's not a big difference here. And so the end outcome, when you're talking about these relative risk reductions and such, was that the tighter control or the more aggressive control by knocking these blood pressures down even lower didn't have any improvement. So the ACCORD trial starts to become a bit pessimistic at this point because, first of all, you kill people if you knock their sugars too low. If you knock their blood pressures lower, you just don't help them. And then, as we'll see later on, the cholesterol got even worse. That if you added extra agents to the cholesterol, that didn't help them either. So this has thrown kind of a big cloud into the treatment of diabetes and the cardiovascular issues. We know that lowering their blood pressure leads to disproportionately better outcomes in diabetics, okay, based on the UK-PDS and numerous other trials. The problem is the very aggressive approach does not seem to improve that. So you get into this argument that, well, if the diabetic goals set 130 over 85 for their blood pressure and they come into your office and they're 137 over 88, are you going to add another medicine? With this, probably not. Matt? The whole purpose is ultimately to find that endpoint, that where it becomes beneficial to take the extra initiative and start a new medication versus where you're like, well, that's close enough. We've gone to pinpoint accuracy to a game of horseshoes and hand grenades. Well, it's in the area. So we're just trying to find where that point is when we stop being so aggressive and cut off extra treatments. So when you look at these, as this slide sort of illustrates what Matt was just saying, where those targets are, 130 over 80 for most patients, 125 over 75 if there's a lot of proteinuria, renal insufficiency, that those lower pressures in general do reduce the risk of end organ failure, cardiovascular events, especially MI and cardiovascular death, and delay the progression of heart failure just by mostly reducing your afterload components.